it wasn't until really the early 90s that women stopped being excluded from early drug studies by the FDA and now are usually a part of most studies. And since it still isn't sort of routine to do that sort of analysis, there are certainly plenty of drugs that are on the market today that were just approved in those days where it was really just men who they were being tested on.
Welcome to Migraine Again, helping you eat, breathe, survive, thrive, and engage better despite migraine. If you or someone you know struggles with migraine often, join us for today's insightful conversation. Now here's your host, founder and managing editor of MigraineAgain.com and co-host of the Migraine World Summit, Paula Dumas.
How many times have you been to the doctor's office and walked away from your appointment thinking, did my doctor believe me? Did he hear me? Am I actually getting the care that I deserve? You know, if you're a woman, today's guest says the answer is probably no. You're actually at greater risk than you realize. She's written a hard-hitting expose that reveals how modern medicine is systematically failing women today. And guys, don't tune out. You'll discover a thing or two about getting better care as well, or help fight for the women in your life. And we'll be back to meet her right after this.
A hot new series is out that you're going to want to binge watch with a bag of popcorn in a dark room. A medical drama with intriguing characters waging gritty, complex battles. Critics call it riveting and insightful. A true original you won't find anywhere else. It's the Migraine World Summit with dozens of new episodes each season. Just one click away. Watch world-leading experts from the Mayo Clinic, Harvard, and UCLA from the comfort of your couch. Get an all-access pass to watch it anytime, anywhere, on demand at migraineworldsummit.com. So put on your comfy pajamas and prepare to binge. You'll be glad you did. You're listening to Migraine Again. For show notes and resources from this episode, check out our program page on migraineagain.com. And now, once again, here's your host, Paula Dumas.
Maya Dusenberry is a compelling voice in the women's health movement. As the editor of the award-winning site Feministing.com, Maya brings together scientific and sociological research, interviews with experts, and personal stories from women across the country to provide the first comprehensive look at how sexism in medicine harms women today. And her new book, Doing Harm, The Truth About How Bad Medicine and Lazy Science Leave Women Dismissed, Misdiagnosed, and Sick, is an eye-opening read for women and men who love them. Maya, welcome to Migraine Again.
Thank you so much for having me.
We're glad you're here. So this is a really timely book. You know, as women are fighting for inclusion and representation in Hollywood, in politics, and business, you know, I've never thought of myself as a feminist, but I am 100% for women getting the health care that they deserve.
Yeah.
We can agree on that. So reading this book for me was really a wake-up call to see the sexism at work in the healthcare system and then try to do something about it. And because migraine really affects 3 times as many women as men, it's a huge women's health issue that's often minimized by the healthcare system. So you're a journalist by trade. How did you first get involved in women's health advocacy?
Yeah, so I've been a feminist writer for many years. As you said, I run a feminist blog, Feministing, and before I became full-time focused on journalism, I actually worked in reproductive health advocacy. So I'd really been, in some ways, interested in women's health issues for a long time and had always written a lot about reproductive health. But it really wasn't until about 5 years ago when I developed rheumatoid arthritis that I kind of started thinking about these issues more broadly. Because of that personal experience, got really interested in learning about autoimmune diseases, which are very, very common, affecting up to 50 million people in the United States. And like migraine, disproportionately affect women. About 75% of people with autoimmune diseases are women. And so I sort of just started wondering why there was so little public awareness about this epidemic, and also started hearing these stories from other women with autoimmune diseases and also other conditions who had experienced really long diagnostic delays and during that search for a diagnosis, really felt like healthcare providers weren't taking their symptoms seriously and brushing them off as stress or anxiety and depression, or just implying they were making it up entirely. So that's kind of what got me going down this path of thinking more about how really kind of systemic and unconscious gender bias has very much shaped what we know and don't know about medical problems, and also really shapes the kind of quality of the care that patients receive.
Fantastic. Well, we're going to get into some of those specific issues to help people understand what you're talking about. With this book, Doing Harm, who did you really want to help, or what policies were you hoping to change?
Yeah, I really, as you said in the intro, I really do hope that sort of everybody who either is a woman or cares about a woman, which is really everyone, will read it, because I think kind of first and foremost, I hope that it helps just ordinary women who've had these sorts of experiences where they've really felt frustrated or dismissed, or really just, feel as though the medical system is not equipped to meet their needs. I hope that they'll really, thanks to this book, be able to see that those experiences are not just sort of, individual bad luck or just a result of their own failings to advocate for themselves, but really that they do reflect these larger systemic problems. And in terms of, the real concrete policies, there are just so many. And there is, a lot of people within the medical profession who have been starting to focus on these problems and come up with solutions. But I do hope that the book, by sort of being a wake-up call for the public, will help kind of spur some grassroots energy and activism towards kind of demanding those changes so that they happen more quickly.
I hope so too. We produce a lot of content to try to help people, patients specifically, advocate for themselves. But before you can be an effective advocate for yourself, you have to kind of realize what you're up against. Mm-hmm. And so what I loved about your book is that it really gets into some of the systemic challenges that few of us realize, because unless you're an industry insider, you wouldn't know those things.
Right, exactly.
Let's talk about a couple of those. You raise several issues that affect the quality of health care that women get. The first is med school training. There's little to no pain management training that doctors get in med school. And at least historically, fewer doctors were women. I believe that's changing quite a bit. Mm-hmm. Tell us what's going on there, and how does that affect the quality of care that we get?
So the sort of statistics about how little pain management training doctors receive were really quite shocking to me. Considering that pain is obviously a symptom of most diseases and is the main symptom that sort of brings patients into the medical system, it's pretty incredible that, doctors are receiving just a few hours on pain management, and there's a real kind of shortage of pain specialists to deal with chronic pain conditions. And I think that is really rooted in the fact that until quite recently, medicine had sort of considered pain to only be important as a symptom, as a sort of warning sign that was indicating some underlying injury or underlying disease. So the idea was that the pain points you to the problem, and then you treat the problem, but the pain itself is sort of, you should treat it, but isn't that important, which really has left a lot of these conditions, pain conditions, like fibromyalgia and idiopathic low back pain and vulvodynia and irritable bowel syndrome, where the pain doesn't seem to be signaling some underlying tissue damage. All of that was kind of just dismissed as psychogenic. And there's only recently been this real shift to considering that kind of unexplained pain as a neurobiological disease in its own right, and a malfunction of the pain processing system itself, and that's starting to kind of shift the way that medical education prioritizes training doctors to deal with pain. But I think that that's clearly not a shift that has happened yet. and is a huge problem for really lots of patients, because obviously acute or chronic pain is a huge burden on the medical system, and especially patients like those with migraine who have pain disorders where the pain is really the main problem.
It's a huge burden on the health system, but it's also a huge burden on the economy and on families and relationships. So I think as we look at the impact of pain, we have to take it seriously. And we have to ensure that medical schools are training their doctors to equip the resolution of the symptoms, specifically the pain symptoms, more seriously in order to get people back to work and to life and to be able to function. So we've talked with a number of our guests about that.
Yes, definitely. And I think it's the point you make about the sort of economic burden and the family burden, not to mention, of course, just the burden on the individual, but, the fact that many chronic pain conditions and autoimmune diseases and other conditions that do disproportionately affect women often strike during youth and middle age, in your 20s, 30s, 40s. And so these really are chronic illnesses that last a lifetime. And so the sort of burden on your earning potential, on your ability to create a family is just staggering, really.
It's true. It's true. A lot of people will say they even put off having a family because their pain is so severe. And so think about the implications of that. One of the next points you talk about is poorly designed research. And I think most people understand that modern medicine is based on research studies. And the way those studies are conducted, though, may be different than most people realize. Can you talk about that?
Yeah, so it really wasn't until the early 90s that it was sort of put on the public radar that a lot of clinical research was really just leaving women out entirely. At that point, there was the National Institutes of Health was not sort of tracking the number of women that were included in federally funded studies, and a lot of the really sort of large foundational studies that had come out in recent years had been entirely on men. And so that did provoke, congressional hearings and public outcry, and some real important changes were made. And so now there's a federal law requiring that NIH-funded research has to include women, and that they have to be included to a high enough amount that you can actually do an analysis to see if there are any sex differences in the results. But there is still no requirement, that research done by the pharmaceutical industry or foundations has to do that. And the FDA requires drug companies to sort of include a breakdown of their results by sex as well as race and age when they submit their applications for new drug approvals, but they don't actually mandate that companies do that analysis. And even for NIH-funded research, I think that the norm is really still that certainly women are usually included, but often the studies are not designed to actually be able to analyze results by sex. And in the published medical journal articles about the study, that is usually totally absent. And then another thing is that when those changes were made to NIH policy to include women, they actually only applied to late-stage clinical research. But when it comes to preclinical research, so studies done with animals or cell lines or tissue samples, that is still firmly the norm to sort of just use male subjects and really not pay attention to potential sex differences at all.
It's kind of hard to believe that for years we didn't have women involved in clinical research. And I think the notion was that it was protecting women, but the effect was harming women because they weren't getting the care that they needed, for example, in heart disease and recognition of heart attack symptoms, right, when they go into the emergency room because they weren't included in some of these studies. Is that right?
Yeah, exactly. I do think it was, partly a sort of protectionist impulse to say, we don't want to expose women and also with their hypothetical, fetuses, if they're of childbearing age, to the potential risks of research, which is not a malicious thing, but yeah, it doesn't really help women as a whole get safe treatments if they're being left out of the research and then are also the people who are needing to use drugs that potentially weren't even studied in them to begin with.
Well, I hope that your book raises awareness among private industry and foundations that are funding research, that they will consider making sure that they've got a good demographic sample, women and men and people of color and various ages who may benefit from the therapies that are being introduced. So you're listening to Migraine Again, and our guest is Maya Dusenberry, author of Doing Harm. And we're going to get into her tips on how to ensure that you're getting the health care that you deserve right after this.
Lost your train of thought again? Lost an opportunity at work? Lost the chance to attend a special event? Navigating a life with migraine isn't easy. Frequent attacks can make it tough to think, to work, and even to show up. Find the help you need just one click away at migraineworldsummit.com. Each year, watch dozens of leading experts, including top patient advocates and headache specialists from the Mayo Clinic, Harvard, UCLA, and King's College London. Get an all-access pass to watch it anytime, anywhere, on demand at migraineworldsummit.com. Stop losing out and get back the life you deserve. You'll be glad you did. This is Migraine Again, encouraging and empowering you in your battle against migraine because you deserve to feel better. You can hear this conversation again or share it with someone who might like to hear it by going to migraineagain.com. And now, once again, here's Paula.
We're back with Doing Harm author Maya Dusenberry to talk about sexism and stigma in women's health and how to fight it. So, Maya, two more issues that you raised in your book. One was diagnostic bias. The pain, especially those types that disproportionately affect women. You talked about migraine, fibromyalgia, interstitial cystitis, IBS, and back pain. Get little respect, a lot of stigma. And that impacts research funding, doesn't it?
Yes, I think it certainly impacts research funding. I think it impacts even just sort of stigma around specialties. I think that doctors who take an interest in conditions like migraine and fibromyalgia, these conditions that really don't get a lot of respect and are stigmatized, even the doctors who get interested in it face some of that stigma. And yes, the funding levels, I think, are very clearly disproportionate to both the number of people who are impacted and just how disabling these chronic conditions can be.
So you said that pain is real when you get other people to believe in it. Can you explain what you mean by that?
Yeah, so that is actually a quote from Naomi Wolf, and it really, I think, speaks well to the fact that pain is just this really subjective thing. Other people can't see it, they can't measure it, they can't sort of independently verify how much pain somebody is experiencing. And so that means that if you are in pain, for your pain to be real in the sense that it's acknowledged and recognized to exist by others so that they can help you, you really have to somehow communicate it. And in order to do that, you have to be considered a sort of reliable, trustworthy reporter. And so if somebody's own testimony about their pain is not believed by others for whatever reason, for all intents and purposes, that's sort of as if it doesn't exist, And I do think it's pretty clear that these pain conditions that disproportionately affect women that you mentioned really, in part, get very little funding because it is so hard for women to do that, to be seen as that credible reporter. Often their reports of pain are distrusted or misinterpreted as psychogenic or just emotional, or just, not taken quite as seriously because it's assumed that maybe women are a little less stoic, a little more prone to exaggerating or being hypersensitive. And I do think that that has clearly been a factor in how little research funding migraine gets.
Well, even beyond research funding, let's just talk about the care that you get in the doctor's office. So you said it's hard work behaving as a credible patient. What can we do to be perceived as more credible patients? What can we bring to those appointments to get the doctor to take our pain seriously?
Yeah, that is such a tough question because I do think that it is very difficult for the individual to sort of manage the way that she's perceived here. And that line about the hard work it is to be a credible patient comes from a study that was looking at this challenge and really identifying the fact that women reporting pain are sort of caught in a lot of catch-22s where, because nobody can independently verify your pain, you have to express it in some way. So you have to communicate it, and so you have to show how much pain you're in, or else use words or, body language to do that. And yet, if you go overboard, you might come across as too emotional, and then you're just hysterical, and then your pain is dismissed. And so a lot of women with pain really spoke to this sense of feeling like they had to be anti-hysterical to the point where they are actually downplaying their pain, which of course is really doesn't help either, because then you're not going to get the pain treatment you need either. So I wish that I had more sort of advice, but I do think it's actually something that's very hard to kind of get out of that trap.
Well, in this case, I think data can be your friend. So if you come in with a dossier of here's what I've experienced over the past 6 months since I've seen you, doctor, or 3 months, whatever the interval has been, even better if you are using an app to track your symptoms, your frequency, your intensity. I'm speaking of migraine right now, but it also applies to other pain conditions. That is data. That's data that the doctor can comprehend and respond to. So there are a couple that are really good at doing this in the migraine space, like Migraine Buddy and Curulator, that produce reports that you can actually bring into your doctor.
Oh, that's great.
And say, here's the frequency of my attacks, the intensity of my attacks, the actual episodes of life that I missed. I missed X days of work. I missed this, I forfeited these theater tickets. I missed my child's play, et cetera, et cetera. And then they understand the impact on your life. And I think in cases like that, you're not perceived as hysterical. You're rational, and you're fact-based, and you're a patient to be dealt with, and they have to take it seriously in a situation like that. So let's move on to the next topic of prescription dosing, because this was eye-opening for me. How do men and women differ in drug dosing and adverse reactions?
Yeah, so men and women differ in terms of both the pharmacokinetics, so how the body is acting on the drug, and the pharmacodynamics of how the drug is acting on the body. And this is sort of an area where we're really just beginning to understand, and different drugs obviously affect the body in different ways, and very few drugs have been sort of thoroughly studied to understand if there are differences, and if there are differences that are big enough to actually matter in terms of dosage recommendations or side effects. But as I said, since it wasn't until really the early 90s that women stopped being excluded from early drug studies by the FDA, and now are usually a part of most studies. And since it still isn't sort of routine to do that sort of analysis, there are certainly plenty of drugs that are on the market today that were just approved in those days where it was really just men who they were being tested on. And so I think we really have a lot of unknowns. And because of that, it's probably not surprising that women actually have much greater likelihood of having an adverse drug reaction than men. They're actually 50 to 70% more likely. And that could be because for sort of a lot of factors go into those differences. So there are differences in hormone levels and speed of metabolism and enzyme levels. But one factor is just that women tend to have a lower average body weight than men, right? And so the fact that we actually just have a sort of one-size-fits-all dose for most drugs instead of sort of accounting for body weight differences, that sort of inevitably leads to women in general being perhaps just overdosed most of the time. And so right now, actually, I believe there's only one drug on the market that officially has different recommended dosage for men and women, and that's zolpidem, which is the active ingredient in Ambien. And you might recall that in 2013, the FDA announced that they were actually cutting the recommended dose in half for women because of evidence that because women cleared it from their body more slowly than men did, they still were drowsy the next morning after taking it, and some had been getting into car accidents. And that was a drug that's prescribed to like 40 million Americans every year, and it had been approved back in the 90s, but had taken this long to kind of see that there was this really pretty significant sex difference there.
Wow. So there's an advocacy opportunity for anyone who's looking for something to take on, is to try to study and examine how much some of the more commonly prescribed drugs affect women versus men in terms of adverse effects and overdosing or underdosing. That would be fascinating to take a look at. So if our healthcare system is putting women at undue risk, what mistakes might we be making that we're making without even realizing it?
Yeah, I think that's a great question. And I think it's really true that we might actually not even know what we don't know right now about women's health and some of these sex and gender differences. And in my book, what I talk about is there being these two sort of interlocking problems that are affecting women's medical care, one being the knowledge gap, which we've kind of talked a lot about, the sources of that, but also this trust gap that, as I said, you have to be seen as a credible reporter of your symptoms, and too often women are not seen as credible, and they're not believed, and their symptoms are not taken seriously. And one of the really dangerous things about that is that I think it sort of serves to erase the fact that we have this lack of knowledge. So if a woman is potentially, reporting symptoms that are actually, side effects of a drug that was untested in women, but if doctors are just saying, oh, well, it's probably all in your head, or just brushing it off as stress, or, just not taking it seriously, then we're missing that piece. And I think that you can sort of see how that could be really pervasive throughout the system. So if it's a woman who's reporting symptoms of heart disease, but there's these atypical symptoms that aren't recognized because heart disease has overwhelmingly been studied in men, then it's going to take us sort of a long time to recognize that there even is this difference. And I think that, so we're just sort of now beginning to acknowledge that there is this really big knowledge gap when it comes to what we know about women's health. And I think that if we started really taking women's accounts of their symptoms seriously and just listening to them and believing them every single time, we would probably find there's even more we don't know.
Once we recognize the problem, more problems will become apparent. So
right.
One of the more encouraging things that I read in your book, and I had heard this elsewhere, is the surge in women who are going into the healthcare professions, becoming doctors and nurse practitioners and PAs. And with more women practicing medicine, these issues should get more attention and improve, right?
Yeah, I think so. I think that I am very hopeful that when women enter the system, they bring a different perspective and can help kind of shake things up. I do think that it's important to sort of remember that a lot of these problems are sort of systemic problems that have gotten sort of entrenched into medical knowledge itself. So I think that, female physicians today are sort of learning the same skewed knowledge that their male counterparts are. So it's not really a guarantee of totally better care, but I do feel optimistic that more women are entering the profession, and I especially feel optimistic from hearing from women that I had interviewed for the book and who had their own experiences as patients with the medical system and had felt dismissed and frustrated, and then actually went to medical school because of those experiences. I think that that's a really optimistic sign that there's sort of going to be a surge of women who are coming into the system knowing what it's like to be a patient and to be a female patient, and to knowing some of those biases, and so are very ready to help move things forward.
Fantastic. So how will you manage your own healthcare differently since writing this book?
Oh, yeah. Well, I mean, I hope to not have to do too much management. My rheumatoid arthritis has been in remission for a while, but I certainly will always be very conscious of doing my own research and not just sort of accepting what I'm told by doctors, because I think it's important that we, of course, respect doctors for what they know, and but also keep in mind the real limitations of medicine, and not be too trusting, and really trust our own instincts if we feel like we're not getting the care that we need.
Healthy skepticism is always wise.
Yes.
So thank you, Maya, for elevating the issues of sexism and stigma in women's health. I think it's an issue that we should be addressing from the patient, physician, research, and policy perspective. So great conversation. And of course, thank you for joining us on Migraine Again.
Thank you so much for having me.
Terrific. And if you'd like to connect with Maya and discover more about these issues, check out mayadusenberry.com. That's mayadusenberry.com/doing harm. And we'll include a link to that as well as how to get her book in the show notes on migraineagain.com. And don't leave yet. You don't want to miss the listener question of the day. But first, if this is your first episode you're hearing, or your 18th or 19th or 20th, we need your feedback. Can you just take a minute to give us a review on iTunes or wherever you get your podcasts? We would really appreciate it, and it will help us to do more quality programs like this one. And next, we'll return with a listener question of the day on migraine and relationships.
A thief is on the loose, breaking into 1 billion homes around the world like yours. This thief doesn't want your electronics or your jewelry. He wants your work days, your wallet, your relationships, and your most precious moments. On the street, he's known as Migraine. Ever heard of him? Lucky for you, your best defense is one click away at migraineworldsummit.com. Each year, watch dozens of leading experts, including top patient advocates and headache specialists from the Mayo Clinic, Harvard, UCLA, and King's College London. Get an all-access pass to watch it anytime, anywhere, on demand at migraineworldsummit.com. You'll be glad you did. Hey, we'd like to hear about your life with migraine and offer some help and encouragement if we can. If you've got a question about migraine, we'll do our best to answer it and might even include it on one of our upcoming podcasts. If you'd like to submit a question, just go to our website, migraineagain.com/question. And Paula, today we hear from a listener who asks a very tough question that I'm sure a lot of people may be struggling with. We heard from Caitlin from New York, who wrote and said, Paula, I'm 21 years old and I have suffered from migraines for 7 years, typically 5 to 11 days per month. My biggest question right now, though, is how can I effectively communicate to my significant other when I'm having my migraines? He's never had one, doesn't understand my pain, and we always seem to be fighting recently. What advice do you have for not letting my migraines get in the way of my relationship? And Paula, she goes on to say that it's hard to spend quality time together when she has a migraine. She even said, he's been thinking of breaking up with me because I've been giving in to my migraines and not striving. Any advice would really help. So what do you think?
Oh, Caitlin, I'm so sorry, but I appreciate you sharing your story, and I imagine that many have felt the pain that you are now experiencing when the person that you love doesn't understand how disabling and frustrating migraine can be. First, let me just suggest that you agree that migraine is part of your relationship. It's like an uninvited guest that really has the power to drive a wedge between you and your boyfriend if you let it. So the key is don't let it, and that's easier said than done. But there are some very practical tips that might help you that have helped many others in our community deal with this very issue. First thing is take your boyfriend with you, if he will go, to your next doctor's appointment. And the doctor can help educate him, and hopefully he will be able to grasp the biology of migraine. And once he understands that, and you'll know if he's committed at this point, if he will go with you to the doctor's appointment. Once he understands the phases, he can actually help you to recognize the early warning signs and treat the attacks more effectively. For me personally, this was kind of a turning point in my relationship with my husband when we weren't just going to the ER together, but we were actually going to the doctor together to talk about my plan and what I was going to do to prevent it, which is the next tip. To develop a migraine management plan and actually put it in writing so your boyfriend knows that you're being proactive, that you are striving. It should include your prevention plan, including some healthy habits that you'll adopt, acute treatment plan, so what you're going to do when you get an attack, and an emergency plan, what you're going to do if your normal treatments don't work. And then I'd encourage you to watch some of the Migraine World Summit talks together. Especially those on the SEEDS lifestyle management with headache specialist Amal Starling, and the talk on relationships with expert Les Parrott. Those would be really useful for you and your boyfriend. And he might be more willing to watch a few talks than to join you at the doctor's office or read articles. So that's just another medium. Heck, you could even share this podcast with him if you like. And if he decides that he wants to break up, just remember that you are not alone. There's a whole community of people on Migraine Again who can support you, many of whom have been through painful health-related breakups. So I hope that's encouraging to you and that you'll keep us posted on how the two of you are doing.
We have a list on our website of doctors who are really in tune with migraine issues. I don't know that we have a list of replacement significant others, but maybe we should add that.
Boyfriend who understands. Here's your downloadable list, right? Anyone can apply. Just apply if you would understand.
Absolutely.
Yeah.
Well, I like the advice that you gave also for those who are maybe in for the long haul as caregivers. It would be great to have them watch the Migraine World Summit, to listen to these podcasts, and to make sure that they're going to these appointments with you so that they can truly grasp what's going on in your life and inside your body, and be able to take it on in a good proactive way rather than just saying, this is interfering with everything we want to do.
Right. It is a huge inconvenience, but that's a great point. I think that episode that we taped with Peter Rosenberger about being a great caregiver,
yes,
and the plight of the caregiver would be a great one for her boyfriend to listen to too. So that's great.
Very good.
Well, Thank you all for listening today. Thank you for listening through this first season. I say season because this is going to be the last episode of our first season. We're going to take a little bit of a break. And if this is the first episode that you've heard, I'd encourage you to go back and listen to all the episodes, which are posted on iTunes and migraineagain.com and wherever you get your podcasts. And then in the meantime, you can give us suggestions of what you want to hear about in our next season, because we'll be planning for that during the break. So thank you for listening. I'm Paula Dumas, wishing you a pain-free day.
Thanks for spending part of your day with us. We hope that you feel encouraged and empowered in your battle against migraine, because you deserve better. If you want to suffer less and live more despite migraine, be sure to check out all the great resources on migraineagain.com. Follow us on your favorite social network and subscribe to our free newsletter and this program. If you enjoyed today's episode, tell a friend about it, and be sure and join us again next time on Migraine Again. You'll be glad you did.